Okay, welcome everybody. This is the ninth chapter in the textbook dealing with joints. Okay, and what we have to appreciate about joints is that these are regions where bones come into either direct physical contact or very close contact and provide some degree of movement. Okay, arthrology is the study of joints, and we can class joints by both their structure and their function. So the structural classes deal with the materials that make up the joint. Okay, what components go into it? And a fibrous joint is held together by dense connective tissue. Remember that connective tissue's job is to seal other tissues together. Okay, so this will be tissue that's similar to the type that you find in ligaments and tendons. A cartilaginous joint has cartilage between the two bone ends, generally fibrocartilage. And a synovial joint is a more complex structure that has bones that almost come together and touch, but they're enclosed in a joint cavity which is filled with a liquid called synovial fluid, which acts as a lubricant and also helps to nourish the hyaline cartilage on the ends of the bones that make up the joint. Okay? So it makes the joint easier to move, but it also makes sure that the cartilage gets the nutrients it needs in order to continue to function properly. Okay? The functional classes deal with the degree of movement that the joint provides. And so the functional classes are synarthrotic joints, which are immovable. Examples include the sutures in the skull, in, for instance, the cranium. Amphiarthroses, which are slightly movable joints, such as the intervertebral discs between the vertebrae of the vertebral column. And diarthrotic joints, which are freely movable and can be broken down into subdivisions depending on the range of motion that they allow. Okay, examples of different classes of diarthrotic joints include hinge joints, pivot joints, ellipsoidal joints, and so on. Okay, motion ranges in these joint categories from no movement to extensive movement. The trade-off there is that the more movable a joint is, the more easily it's injured. And the structure of each joint determines its mobility and stability in addition to the ligaments that hold the joint together and the tendons that cross it. Okay? So that's the relationship we talk about, right? The sutures in the skull are immovable, but they are rarely injured, whereas something like the shoulder joint or the hip joint, which is extremely movable, is easily injured. Okay, so you can see some examples of the relationship between mobility and stability in the joint. Bottom line, the more movable, the more easily injured. The less movable, the less easily injured, and the more stable. Okay, so makes sense, right? The fibrous joints are connected by dense, regular connective tissue without a joint cavity, and they're basically immovable. Okay, these include Gomphoses, which are characterized by the joint between the teeth and the sockets in which they sit in the jaw, which are called alveoli. Sutures, which hold together things like the cranial bones, and Syndesmoses, which are thickenings near a joint that are held together by dense, regular connective tissue, such as you see at the distal tibiofibular joint. Okay? So there's the gomphotic joint, right? The tooth sits in the socket, the gomphotic ligaments stabilize the position of the tooth, and the degree of movement is minimal. Okay? When you have gingivitis progressing to periodontal disease, one of the things that happens is that these ligaments, these gomphotic ligaments, loosen and the teeth become mobile in the jaw, and frequently they end up having to be pulled as a result. Okay. Sutures are basically areas where flat bones come together and are held by fibrous connective tissue as if they were puzzle pieces fitting with each other and have interlocking edges. Okay. So this increases the strength and reduces the risk of fracture for these joints. In childhood, they have yet to fuse, and there are cartilaginous areas between the flat bones that eventually disappear by the time we leave childhood. Okay, so um, in childhood they're called fontanelles. Okay, and then they become sutures over time. And the purpose of the fontanelles is to allow the growth of the brain, which is a little bit more rapid than other portions of the nervous system, okay, and other components in the body. But it also allows the cranium to deform slightly as the head passes through the birth canal so that the baby can get out, okay? So it's flexible. A syndesmosis is basically an interosseous membrane that holds two bones to each other. We find this between the radius and ulna and between the tibia and the fibula. They function as amphiarthroses because they allow some movement. Okay, for instance, they provide pivot points for the long bones in the forearm. Okay, a cartilaginous joint has cartilage between the two bones, no joint cavity, and they are slightly movable. Examples include Synchondroses and Symphyses. Okay, a Synchondrosis is basically the growth plate at the ends of long bones. Okay, so the idea here is that between the epiphysis and the diaphysis, there's a region of cartilage that is sustained until the end of puberty that allows for longitudinal bone growth to continue. Okay, and so the epiphysis and the diaphysis are linked by this area of hyaline cartilage, which is a remnant of the cartilage model that used to be the entire structure of the bone, okay, before it was replaced by osseous tissue. Another example is the articulation of the first rib with the sternum, particularly down here in the manubrium, okay? So you can see here that the hyaline cartilage bridges the area between these two bones, and there is a slight degree of movement. In a symphysis and in the intervertebral discs, we have fibrocartilage between the two bones, allowing slight mobility. The fibrocartilage is resistant to compression and acts as a shock absorber, but does produce a degree of movement that allows the entire vertebral column a relatively high degree of movement, because when you add the small degree of movement between each intervertebral disc, the net effect is to provide a lot of movement. And the same is true of the pubic symphysis, particularly during childbirth, when a hormone called relaxin causes the structure of the fibrocartilage to become a little bit more flexible, and that lets the baby's head pass through the birth canal more easily. Costochondritis is an inflammation of the costochondral joints in the rib cage and causes chest pain. The cause could be trauma or infection, and it may be mistaken for an MI, for a heart attack. And we treat this with NSAIDs like ibuprofen and naproxen. Remember that an NSAID is a non-steroidal anti-inflammatory drug. That's what the acronym stands for. We prefer to use NSAIDs to control inflammation over steroidal anti-inflammatories because long-term use of steroidal anti-inflammatories can elevate blood sugar levels and suppress immune function to the point where infection becomes easier to sustain. Okay? Examples of steroidal anti-inflammatories include things like cortisol and cortisone. Okay? A synovial joint is a more complex structure. The bones are separated by a joint cavity. This includes most of the joints in the body. These are diarthrotic joints, so they're freely movable. They all have an articular capsule and a joint cavity filled with synovial fluid, which is produced by cells that line the joint capsule called synoviocytes. Articular cartilage, which is hyaline cartilage at the ends of the bones, pads and protects the ends of the bones. And then we usually also find ligaments, nerves, and blood vessels running through the joint. And you can see an example of a synovial joint here, right? This is the distal end of one bone and the proximal end of another. The synovial fluid is here. You can see the articular cartilage, the hyaline cartilage at the ends of the bones. There is the epiphyseal line. There's the epiphysis, right, here and here. This is diaphysis, here and here. There's yellow marrow, right? And there are the synoviocytes lining the internal portion of the joint cavity. And then out here, you've got the fibrous layer, which is dense, irregular connective tissue, resisting trauma and movement in many different directions. Okay? And as a result of the way the pieces fit together, you have a certain degree of movement. Okay? So that's the fibrous layer and the inner synovial layer, right? The synovial fluid is a filtrate of blood, and it nourishes the hyaline cartilage at the ends of the bones and lubricates the joint so it moves without friction. And so that's one of the reasons why bone surfaces that participate in joints are rather smooth, right? Because we don't want friction produced during their use. Now, one of the limiting factors here is that the cartilage relies on diffusion of oxygen from the perichondrium in order to nourish the cartilage and keep it functional. In this case, the blood supply is outside the joint capsule, okay? Whereas in other types of cartilage, it actually surrounds the cartilage itself. Remember that because of the nature of cartilage being avascular, diffusion is the mechanism to get the nutrients and the oxygen to the chondrocytes, which are trapped inside the matrix. And that's why cartilage is rather thin compared to bone, which is a vascular structural connective tissue. The articular cartilage, again, is hyaline cartilage on the bone surface at the joint. It reduces friction, it cushions the ends of the bone, and prevents damage. There's no perichondrium in its avascular tissue, as we pointed out. The cavity is the space, and the synovial fluid is the filtrate of blood that fills it and lubricates the articular cartilage and nourishes the cartilage and also acts to remove wastes. It's made up of glucosamine and chondroitin in large part, but there's also dissolved oxygen in there as well, and CO2 as a result of metabolism from the cells that are surrounding the fluid, and it acts as a shock absorber. Ligaments are just dense, regular connective tissue that attaches bone to bone, and this stabilizes the joint and permits movement in certain directions and not in other directions. Extrinsic ligaments are physically separate from the capsule, while intrinsic ligaments are within the capsule itself, and then there are even in some synovial joints intracapsular ligaments that are within the capsule. Okay, all the ligaments have very poor blood supply, and as a result, if they're ruptured or snapped in some way, generally they have to be surgically repaired or replaced. Sensory nerves and blood vessels are numerous in the synovial joints, and they detect pain, and they also report on proprioception, which is our ability to detect the position of our body in space, either while we're still or while we're moving, and this allows us to maintain our balance. The tendons attach muscle to bone, and they're made of the same material as the ligaments are. They're not a part of the synovial joint, but they do stabilize the joint and limit the movement of the joint to movements that the joint is designed to provide. Okay, so this is another way to make sure, for instance, that your knee only bends in one plane and your elbow only bends in one plane. The tendons that cross the joint from the muscles that cross the joint help to determine that, along with the ligaments and the shapes of the surfaces of the bone that fit together in the joint. Bursae are basically sacs that are filled with synovial fluid, and they're They're going to have a synovial membrane just like the joint capsule does, and they're in places where bones, ligaments, muscles, and skin can potentially rub together, and their point is to alleviate and remove friction and allow movement without pain. Okay? So sometimes they inflame, and this is a condition known as bursitis, and it's extremely painful. Okay? And it can be caused by trauma or infection. Often it's a result of what we call repetitive motion injuries, where we do the same movement over and over and over again, and the net result is that it produces an inflammatory process in these sacs. So you can see here in the knee some examples of where the bursa are. They're shown here in blue, right? There's your pre-patellar bursa in front of your patella, your kneecap, right? Your infrapatellar bursa, which are below the kneecap. And then you've got bursa that are underneath the attachment, the origin point for the gastrocnemius, right, which crosses the back of the knee and the back of the ankle. Okay, and the purpose of all of these, again, is to allow movement without pain, right, to reduce friction. So they act a little bit like ball bearings do in roller skate wheels. Tendon sheaths are sacs filled with synovial fluid that wrap around tendons and lubricate them to reduce friction. We find these, for instance, in the wrist and the ankle. And then there are fat pads that act as cushioning and fill spaces where the joint shape could potentially change. Okay? Some examples of tendon sheaths are shown here. You can see them wrapped around the tendons that attach to the phalanges and to the metacarpals. Okay? And the idea here is that there's extensive movement, there's pretty tight spacing here, we don't want a lot of pain, and so we lubricate as much as we possibly can, and as a result we can generate significant movement without inflammation. Okay? Now within the synovial joint category there are subdivisions, right? And these are grouped by the number of planes through which the joint can move. A uniaxial joint moves in one plane, a biaxial in two, and a multiaxial in multiple planes. Okay? An example of a uniaxial joint be your elbow, right? Only moves in one plane. You can flex and extend your forearm using your elbow. Okay? A biaxial joint would move in two planes. An example would be the joint between your proximal phalange, right, the finger bone closest to your hand, and your metacarpals, because you can move your finger up and down, and you can also move your finger side to side. Okay, and that's an example of an ellipsoidal joint as well. And then multiaxial can move in many planes. An example of that would be your shoulder and your hip. Okay, we can group them based on their shapes of their surfaces as well. Plane, hinge, pivot, condylar, saddle, and ball and socket joints are all examples of different types of synovial joints that permit different ranges of movement. Okay, a plane joint allows gliding or sliding movements, and it's found in the wrists and the ankles. A hinge joint is a convex surface within a concave depression. Examples include the elbow and the knee. And a pivot joint allows rotation around the long axis. Examples would be the articulation of the radius and the ulna, and the articulation of the atlas and the axis. Okay, usually there's a ring of dense regular connective tissue that completes the pivot joint. All right, so that the pivoting bone kind of rolls within a circular socket. Okay. A condylar joint is an oval protrusion and an oval depression. These are generally biaxial. And the saddle joint is a unique one, and that is between the metacarpals under the thumb, okay, and the proximal phalange. All right, and this allows a movement called opposition, where the thumb can touch the tips of all the other fingers, and that allows us to write and use tools. Okay, very important joint. Opposable thumbs. Ball and socket joint, your shoulder and your hip, right, which is a round head fitting into a round depression. These are the most movable joints. They're multi-axial, and they're the most easily injured. Gliding joints are found again in the wrists and in the ankles, and they're also found in the vertebral column where the superior and inferior articular processes touch. Okay, so as your vertebral column moves, right, the spinous processes, the underside of the spinous processes glide against the surface of the vertebrae beneath it, right, and that permits movement in the gliding direction. Okay, it's a difficult movement to demonstrate. Angular movements are easy to demonstrate, right? And this is basically changing the angle between two bones from anatomical position. Examples of angular movement include flexion and extension, hyperextension, lateral flexion, abduction and adduction, and circumduction. Okay, flexion is decreasing the angle between two components from anatomical position, such as flexing your forearm, right, bending your elbow. Extension is the opposite of that, increasing the angle between two components from anatomical position. And then hyperextension is going beyond anatomical position. Okay, lateral flexion is movement of the trunk of the body along the frontal plane in a lateral direction, and this happens between the vertebrae in the cervical and in the lumbar region. Okay, examples of these movements are shown here. Follow the arrows, right? There's flexion. The opposite is extension, right? Going back to anatomical from bent, and then hyperextension going beyond that. So you can do the same thing with your wrist, right? From anatomical, you could flip your wrists up from anatomical. You could flip them back to anatomical position, and you could also flip them back from anatomical position. That's hyperextension, right? In the elbow, you've got flexion and extension. No hyperextension, because that would be moving your forearm. Let's do this. Let's draw this. That would be moving your forearm this way, right? And that's not allowed. So we put hyperextension, hyperextension. Not permitted. Sorry about the and we'll put a line through it, right? Not going to happen. Okay. Same with your knee, right? You can flex your knee, you can extend your knee, but if you were to hyperextend your knee, it would be that, right? And that is again not allowed. Okay, unless the joint's been traumatized. Okay, and then there's lateral flexion over there. Abduction is movement away from the midline of the body, the midline of the body being a plane that would cut the body into a right and left half, and adduction is movement back towards that midline. So examples are here, right? Abduction of the arm would be raising it away from your side, and adduction would be bringing it back to, right? Abduction of the wrist, flipping the wrists laterally outward, okay? And adduction would be flipping the wrist back to anatomical. There's abduction and adduction of the hip and of the fingers, okay? And then circumduction is just transcribing a cone in space, right? Where one end of the bone stays relatively stable, and then the other end is moving in a circular pattern. So we can do this at the shoulder and at the hip because they are ball and socket joints. Rotation is just where a bone pivots on its long axis, okay? So you can do this between the atlas and the axis, and you can do this between the radius and the ulna of your arm, right? Lateral rotation, an example would be turning your head to the right or to the left, right? Medial rotation would be taking that turned head and turning it back to center, okay? In the forearm, pronation is flipping your forearm so that the back of your hand faces forward, and supination would be turning it back to anatomical position, okay? So pronation is medial rotation, and supination is lateral rotation. And examples of that are shown here. Okay, so you can see rotation, right? You can rotate the forearm, you can rotate the arm, you can rotate the thigh, right? You can rotate the head. Okay? Then there's depression and elevation. All right. In depression, we pull an object down towards the feet, and in elevation, we lift an object up. Okay. Examples here. Right. You can depress your shoulders, which is to let them sag. Right. Or you can elevate your shoulders, which is to shrug them. Okay. Dorsiflexion and plantar flexion are another couple of special movements. In dorsiflexion, you lift the top of the foot up with your heel still on the ground because the top of your foot is called the dorsum, and the angle between the top of the foot and the leg, the lower leg, is decreasing. We call it flexion. And then plantar flexion is pointing your toe because that's causing the plantar surface of your foot, which is the bottom of your foot, to have an angle that's less than anatomical, which would be you standing flat-footed on the floor. Okay. Eversion is like when you take the sole of your foot and you flip it outward. Okay, evert the foot. Inversion happens often when you twist your ankle. Right, the sole of your foot turns inward, and sometimes you tear tendons and ligaments that stabilize the ankle here. Okay. So again, intertarsal joints are where this is going to occur. Protraction and retraction. You can do this, for instance, with the mandible. Protraction to jut the mandible out and retraction to pull it back. You can do this with the scapula as well, right? You protract your scapula when you throw or you punch, and you retract your scapula when you stand at attention, right, and square your shoulders. Okay, so those are a couple of examples. In opposition, we just take the thumb and we touch the tips of all the different fingers, and that's because the joint between the proximal phalange of the thumb and the metacarpal under it is a saddle joint, special kind of joint. And reposition is to go back to anatomical. Okay. We can refer to joints using mechanical terms. Okay, a lever is a mechanical device that allows you to apply force to an object for either increased ability to move a heavy object or increased ability to control the movement of a particular object. Okay, and so the fulcrum is the point at which the movement occurs. The effort is the force that's applied to the lever. The resistance is the force you're working against. The effort arm is the part of the lever that runs from the fulcrum to where the force is applied, and the resistance arm is the lever from the load to the fulcrum. Okay, so you can see some examples here, such as in a pair of scissors, right? The effort is applied to the handle, the fulcrum is here, and the resistance is here. Okay, and there's the effort right there at the end of the scissor. Okay, in a teeter-totter, right, you can see the effort arm here, there's the fulcrum, and there's the resistance arm. Okay, bottom line, the longer the effort arm and the shorter the resistance arm, the greater what we call the mechanical advantage, meaning you don't have to put as much effort into moving the resistance as you would if the effort arm was shorter or at the same length as the resistance arm. An example would be the way that you jack up your car when you have a flat tire, right? When you get your jack out, the handle of the jack is relatively long compared to the part of the jack that's attached to the car that's moving it up and down. And so when you apply the force to the jack, you don't have to be Hercules in order to get the car off the ground. All you have to do is use the mechanical advantage of the lever arm, and that multiplies the force you're applying many-fold, okay, and allows you to move a much heavier resistance. Okay, another example here, right? You've got the fulcrum here with the articulation between the atlas and the occipital bone of the skull, and then you've got the effort, which are the muscles that cross that joint, and then the resistance, which is the weight of the head. Okay? So you can see here with a second class lever, a small force can balance a big weight. Okay? In here, in the second class lever, the fulcrum is a long way from the effort, and that means that you've got a huge mechanical advantage. Okay? You have this, for instance, in a wheelbarrow. You can see the diagram here. It doesn't much happen in the body. An example here might be standing on the tips of your toes, right? The effort is applied here. The resistance is the weight of your body down, and the fulcrum is going to be the point of angular movement between the metatarsal and the tarsal. Okay? A third class lever, the effort applied is between the resistance and the fulcrum. Example would be a pair of forceps. Okay, you can see the resistance here, the effort, and then there's the fulcrum back there. An example is the elbow joint, right? There's the fulcrum. The effort is the attachment point of the muscles that cross the elbow to the radius, or in the case of the brachialis, to the ulna. Okay, and then the resistance is the weight of the forearm itself. Okay, and so again, you do get a bit of a mechanical advantage because the effort is some distance from the fulcrum, right, and allows you to control the force more easily. Okay. The temporomandibular joint is a special kind of joint. It's the articulation between the mandible and the temporal bone, and it's formed by the condyloid process of the mandible with the mandibular condyle of, or with the mandibular fossa of the temporal bone. Okay, so it's an oval protrusion that's fitting in an oval depression, and it allows elevation and depression of the mandible, but it also allows side-to-side movement. There's an articular capsule that allows the range of motion, and there's an articular disc of fibrocartilage in there, and it divides the synovial cavity into two chambers. The sphenomandibular ligament extends anteriorly and inferiorly from the sphenoid to the mandible, and the temporomandibular extends inferiorly and posteriorly from the articular tubercle to the mandible. Movements, like we said, elevation and depression, and movement from side to side. And you can see, again, the articulation here. You've got an oval protrusion. You can see the oval protrusion right here, right? And you've got an oval depression, all right? So this is temporal bone. This is mandibular fossa, all right? So what I want to talk to you a little bit now is TMJ syndrome. So take a listen.
Let's look at our animation model. We'll call her Sue. As we look inside to see Sue's muscles, bone, and teeth, we see how a healthy bite and jaw joint work together. As the mouth opens, notice how the jaw bone rotates in the joint but stays braced against the skull with the cartilage disc cushioning between the two bones. As Sue closes, notice how the jaw rotates back, staying braced and cushioned at all time until all teeth come into contact at the same time. At the end of the chewing stroke or opening and closing cycle, all the teeth have come together into the bite and the jawbone and disc are braced against the skull. What would it look like if Sue had a bite problem? Her jawbone starts off braced in the joint, but as she closes, her teeth come into contact prematurely in the back so that in order for the rest of her teeth to come together, her jaw has to come out of its socket, down and backward to avoid the early contact, which can be damaging and painful to the teeth. This is why we say that Sue has an unstable joint and is not braced throughout the opening and closing cycle. During the daytime, Sue's brain programs her muscles to make sure that the bite always comes together evenly, avoiding the early tooth contact in the back of the mouth by keeping the jawbone out of the joint socket. During sleep, the brain wants to rest and not worry about constantly programming the muscles, so instead it tells the muscles to either clench or grind the teeth so that they stay locked together. The jaw stays out of the socket all night and the muscles of the head and neck are working constantly during sleep. Since these muscles get overworked every night, they become fatigued, leading to spasms and inflammation. The result of the chewing system being constantly overstressed is breakdown of the teeth, gums, bone, and joint, and finally pain such as headaches and migraines, neck and shoulder pain, or popping and clicking of the jaw joint, among other symptoms. With an orthotic that bioaesthetic dentists call a mago splint, the jaw-bite relationship can be stabilized. Notice how the jaw joint is staying braced in the joint against the cartilage disc when the teeth bite against the mago. Sue has been treated with the mago splint to relax the muscles and let the jaw joint stay in its proper location. This is a diagnostic process that helps the dentist and patient learn what is causing the pain and what could change if the jaw joint stays in place. From this information, a final treatment can be formulated. Treating this problem will result in the bite and jaw joint becoming healthier and the muscles getting well-deserved rest. The result is that Sue will probably feel and sleep much better.
So, as you saw in the previous video, the articular disc here can be forced out of its normal position, and you get these clicking or popping sounds when you open or close your mouth, and this produces joint pain. That's arthritis, right? Can be pain in the paranasal sinuses, which are attached to the nasal cavity and are inside the maxilla and the sphenoid and the ethmoid bone and the frontal bone, okay? And it can have an effect on your eardrum, your oral cavity, your eyes, and your teeth, okay? The next joint we want to talk about is the shoulder joint. This is a saddle joint formed by the articulation of the nubrium and the sternoclavicle. So it's a lot like the shoulder joint between the proximal phalange of the thumb and the metacarpal under there. There's an articular disc that splits the joint into two parts and forms two synovial cavities. The movements, well, elevation, depression, circumduction, okay? And stability is provided by the fibers and the ligaments here and makes the joint relatively stable. So you can see here the articulation between the sternum and the clavicle, right? There's the two cavities. There's synovial fluid in there, all right? And there is the manubrium, right? And just to orient you, right, this is the articulation of the first rib with the manubrium. This is all dense, regular connective tissue right here with no joint capsule at either end, okay? The acromioclavicular joint is a plain joint formed from the acromion and the lateral clavicle. Fibrocartilaginous articular discs in the cavity divide it into two chambers. The joint capsule is strengthened by the acromioclavicular and the corasoclavicular ligament. If this gets torn, the acromion and the clavicle don't align anymore, and we call that a shoulder separation. And then finally, the glenohumeral joint is the articulation between the proximal head of the humerus and the glenoid fossa of the scapula. All right, this is a ball and socket joint and can move in any direction. It's relatively unstable and easy to dislocate because of the high range of movement. Fibrocartilaginous glenoid labrum is what primarily stabilizes the front part of the socket, okay, and is often torn by athletes such as pitchers and quarterbacks. And this results in the need for something called Tommy John surgery, who was the first athlete. He was a pitcher for the Dodgers that got this surgery back in the 70s, okay, and he was able to pitch again. And before that groundbreaking surgery, usually when you tore your labrum, that was the end of your pitching career. Okay? There's a lot of bursa here to lubricate tight spaces between things like the acromion and the proximal head of the humerus, okay, between the coracoid process and the rest of the scapula, and that decreases friction, okay. There are ligaments and tendons, coracohumeral, coracoacromial, and glenohumeral, all stabilize the joint, and the tendon of the long head of the biceps brachii participates in this as well. So this all becomes part of the labrum, okay? The stability of this joint is the result of a group of muscles called rotator cuff muscles, and the acronym for this is SITS, S-I-T-S, which stands for supraspinatus, infraspinatus, teres minor, and subscapularis, okay? The supraspinatus lies in the supraspinous fossa and runs over the top of the shoulder and attaches to the proximal humerus. The infraspinatus runs from medial to lateral across the back of the shoulder and attaches to the proximal humerus, and the same for the teres minor. And then the subscapularis actually comes from back to front, okay, crosses from medial lateral from the back of the shoulder to the front of the shoulder, from the medial to the lateral side, and attaches to the proximal humerus, okay. And so those all permit different types of movement, but they also stabilize the position of the humerus in the shoulder joint. And you can see examples of the ligaments here, okay, and then the ligaments stripped away, right? And then if we look at the structure of the socket in which the humerus sits with the humerus removed, you can see how shallow the glenoid fossa is, and that most of the socket is formed by cartilaginous or dense regular connective tissue from ligaments and tendons, okay? And this is why this is so easy to tear. The bony supports of the shoulder are relatively minor, and they're made up primarily of the coracoid process, the clavicle, and the acromion that run across the top of the shoulder socket, right? Everything here in the front is either cartilage or dense regular, okay? And as a result, when you're throwing, which is a forward movement, it's easy to tear this, right? Boxers, pitchers, quarterbacks, all can easily damage this relatively soft tissue compared to solid bone. So this is easier to hurt than a hip is, because a hip has a deeper bony socket. You can see here in a coronal section the bursa and the tendons that cross the joint and stabilize it as well, okay? Some common injuries: shoulder separation, which is usually an AC separation, acromioclavicular. You get pain when you abduct the arm more than 90 degrees, and the acromion is more prominent. Glenohumeral dislocations occur when fully abducted and then you hit the humerus, and the shoulder appears more flattened and squared off, so the humeral head is in front and below the glenohumeral capsule, okay? So what follows is a discussion of the shoulder joint, okay? And I will join you with the elbow after that.
The upper limb is normally highly mobile. This mobility is due to the wide range of movements which can occur at the shoulder joint itself. and also to the fact that the shoulder girdle is restricted only by its attachment to the skeleton through the clavicle. The shoulder is required to absorb much of the force that is applied to it, or transmitted through the upper limb, making it prone to injury. Any restriction of its movement can be disabling and of serious concern to the patient. The shoulder normally has a smooth muscular profile. This is created by the deltoid muscle, which surrounds the shoulder on 3 sides. It arises from the spine of the scapula posteriorly, from the acromion process laterally, and from the lateral third of the clavicle at the front. Most of the fibres of this muscle converge on the lateral side of the arm and are inserted into the deltoid tubercle, midway down the lateral side of the humerus. This muscle is a powerful abductor of the upper limb and can be clearly seen in this prosection. The only bony attachment of the upper limb to the trunk is via the clavicle. The clavicle forms a joint laterally with the acromion process and is also anchored by ligaments to the coracoid process of the scapula. At its medial end, it is secured by ligaments to the first rib and forms a joint with the sternum. If the shoulder is rotated, some idea of the range of movements which occur at this joint can be appreciated. Several large muscles attach the upper limb to the chest wall. Anteriorly, the largest of these is pectoralis major, which can be seen here arising from the sternum, from the costal cartilages, and from the clavicle. The fibres twist and are inserted onto the front of the humerus, on the lateral lip of the intertubercular groove. This muscle is a powerful adductor of the upper limb and is also involved in its medial rotation. Looking from behind, the medial border of the scapula can easily be defined, together with its inferior angle and its spine, running transversely towards the tip of the shoulder. The scapula is attached to the trunk by a broad triangular-shaped muscle called the trapezius, which arises mainly from the spine of the scapula. The extent of this muscle can best be seen at dissection, where we clearly see it attached to the vertebral column and its fibres converging on the spine of the scapula. Among other movements, this muscle enables rotation of the scapula, causing the glenoid cavity to point upwards, which it does as the upper limb is fully elevated. Deep to trapezius are the rhomboid muscles and levator scapulae. These two muscles hold the medial edge of the scapula close to the posterior chest wall. Together with the upper fibres of trapezius, the levator scapulae is also responsible for elevating the scapula during shrugging of the shoulders. Below trapezius is a broad muscle called latissimus dorsi, which arises from the posterior chest wall and is inserted into the front of the humerus. The latissimus dorsi is a powerful adductor and medial rotator of the upper limb. Finally, among the major muscles linking the upper limb to the trunk is serratus anterior. This muscle arises from the lateral chest wall and passes posterior medially to be inserted into the medial border of the scapula, passing on its way between the blade of the scapula and the rib cage. This muscle draws the scapula forward around the chest wall, as when folding the arms in front of the body. The shoulder joint is a synovial joint formed between the pear-shaped glenoid fossa on the scapula and the hemispherical head of the humerus. In life, the fossa is deepened and the articular surface extended by a rim of fibrocartilage known as the glenoid labrum. Stability at the joint is provided mainly by a group of muscles arising from the scapula and passing to the head of the humerus. They consist of the supraspinatus muscle superiorly, the infraspinatus and teres minor posteriorly, and the subscapularis muscle anteriorly. These muscles are referred to collectively as the rotator cuff. Their tendons reinforce the capsule of the joint and pull the head of the humerus firmly into the glenoid fossa. The rotator cuff surrounds the joint on three sides, the cuff being deficient inferiorly. And, as the name suggests, it can also rotate the head of the humerus, although this is mainly done by the long muscles we've already looked at, which are inserted into the shaft of the humerus. Running through the joint capsule is the tendon of the long head of biceps brachii. This tendon also helps to stabilize the joint. There are a number of bursae associated with the shoulder joint, two of which are especially important. The subscapular bursa lies anterior to the scapula, separating the tendon of subscapularis from the bone. This bursa is often in continuity with the synovial cavity of the shoulder joint. The other is the subacromial bursa, which lies between the underside of the acromion process and the tendon of the supraspinatus muscle. A wide range of movements are possible at the shoulder joint. These include forward flexion and backward extension of the arm, abduction of the arm away from the body, and adduction towards it, as well as a combination of all these known as circumduction. The arm is also able to rotate along its long axis by about 30 degrees medially and 60 degrees laterally. Nearly the full range of this rotation can be seen by moving the hand from the small of the back to the back of the head. The range of movement of the upper limb is increased by simultaneous movement of the scapula on the chest wall. It can be raised or depressed, or may glide forwards and backwards around the chest wall. The scapula can also be rotated around a horizontal axis. Often, movement at the shoulder joint involves complex integration of all these elements. Damage to the shoulder can occur at any age. An inflammation of the shoulder is quite common. It can be caused by excessive strain or rupture of the rotator cuff. The supraspinatus part seems to be especially vulnerable. If this is damaged and the subacromial bursa becomes inflamed, abduction of the arm can be extremely painful, as the tendon of supraspinatus presses against it. In the elderly, a similar situation can arise caused by irritation from calcified deposits within the tendon of supraspinatus, causing tendinitis. A direct blow to the side of the shoulder can result in the dislocation of the Acromioclavicular Joint and rupture of the associated ligaments. As a result, the heavy shoulder collapses and the acromion process comes to lie below the lateral end of the clavicle. The most common fracture in this region is that of the clavicle, often in the middle third, which typically breaks as a result of a fall on the outstretched arm. When complete fracture occurs, the clavicle no longer acts as a strut, and the powerful adductors of the arm pull the shoulder medially, so that the broken ends of the clavicle overlap. At the same time, the medial portion is elevated by the clavicular fibers of the sternocleidomastoid muscle. The shoulder joint is one of the most commonly dislocated joints. This typically occurs when force is applied along the length of the arm when abducted. The head of the humerus is forced inferiorly where the rotator cuff is absent. The head comes to lie anterior to the scapula, tearing the subscapular bursa. At the same time, the head becomes medially rotated, due mainly to the unopposed action of pectoralis major and latissimus dorsi, which are powerful medial rotators of the arm. This is usually known as an anterior dislocation. Dislocation can also cause damage to the axillary nerve, which normally winds around the neck of the humerus, becoming stretched, crushed, or even severed. If this does happen, innervation to the shoulder joint, to the deltoid muscle, and to a small area of skin on the lateral side of the arm is impaired. Care must be taken when reducing the dislocation, as the axillary nerve can be damaged at this stage too. Similar damage can occur as a result of fracture at the surgical neck of the humerus. In summary, the shoulder is a ball and socket joint which is capable of a large range of movements. This mobility is achieved by sacrificing stability. Stability at the shoulder rests largely on the muscles and tendons around the joint, and injuries at this site are common.
So the elbow joint is an example of a hinge joint, a synovial joint, and it is the articulation between the distal head of the humerus and the radius and the ulna. Okay, the primary portion of the hinge part of the elbow joint is the articulation of the trochlea with the trochlear notch of the ulna, and then the remainder is the articulation of the capitulum with the proximal head of the radius. Okay, so there's a humeral ulnar and humeral radial joint, right? Humeral ulnar is the hinge movement. Humeral radial is primarily to permit it can assist a bit with the hinge movement, but primarily it's the idea that the radius can rotate over the top of the ulna when you pronate and supinate, okay? Because of the nature of the articulation between the radius and the ulna there, okay? One joint capsule encloses the whole thing, and so you can see an example of it here, right? And again, this is a perfect example of a joint whose range of movement is dictated primarily by the shapes that fit together in the bone, but the ligaments also contribute quite a bit to the stabilization of the joint, right? The fact that the coronoid process of the ulna fits into the coronoid fossa, okay, and the so there's the coronoid and the coronoid fossa, and then the olecranon fits into the much deeper olecranon fossa. That allows these protrusions to fit into these depressions relatively easily. And then there's the trochlea sitting in the trochlear notch. And look at the synovial membrane that surrounds the entire thing. Okay, so there's a hinge joint right there. And then you can see the articulation of the radius, and the capitulum would be on the other side of this joint. Okay, so this is a right elbow, and this is the same elbow with this connective tissue cut away so that you can see inside. Okay? The articular capsule of the elbow is thick. The bony surfaces of the humerus and the ulna interlock like puzzle pieces, and the strong ligaments reinforce it. The radial collateral stabilizes the joint laterally and extends around the radius. The ulnar collateral is going to stabilize the medial side of the elbow joint, and the annular ligament runs around the neck of the radius and is going to attach the radius to the ulna, and that is really part of the pivot joint between the radius and the ulna, so that you can do pronation and supination. Okay. Sometimes you can have what's called a subluxation, where the head is pulled out of the annular ligament. This occurs in children because the annular ligaments are thin and the radial head's not completely formed. And what the doctor may do is reduce the dislocation, putting the radial head back into the ligament and allowing it to heal. Okay. Now, the hip joint is the counterpart to the shoulder joint, and it's the articulation of the proximal head of the femur, which is round, with the acetabulum, which is a depression, a deep depression in the coxal bone. It's a more stable joint, but it still provides movement in every plane, okay? You can see that there are numerous ligaments that stabilize it, right? Iliofemoral, ischiofemoral, pubofemoral, all cross the joint and stabilize it, right? And there are features on the humerus, lesser and greater trochanter, that also serve as attachment points for some of these ligaments as well. They are also attachment points for muscles that cross the joint and control its movement. But you can flex, you can extend, you can abduct, you can adduct, you can circumduct, all at the hip. Okay. You can see here in the cutaway the proximal head of the femur sitting in the acetabulum. This is the ligament of the head of the femur. Blood vessels go in through here, right? There's the epiphysis. There is the epiphyseal line. There's one there, and there's one there. Spongy bone beneath compact. There's the articular cartilage, okay? So again, a weight-bearing joint, right? This is one of the places where if you're going to get osteoarthritis, it's going to show up first in places like the hip, the knee, and the ankle, because those are weight-bearing joints. The hip is secured by the articular capsule, the ligaments, and the muscles. The articular capsule runs from the acetabulum to the trochanters, and it closes the femoral head and neck. Retinacular fibers are a component of the articular capsule that run around the neck of the femur, and the retinacular arteries go in and out there and supply blood to the femur's head and to its neck. And then the ligaments are just named for the components that they connect, right? Iliofemoral ligament runs from the ilium to the femur, ischiofemoral from the ischium to the femur, pubofemoral from the pubis to the femur, okay? They get tight when the hip is extended. The ligament of the head of the femur, known as the ligamentum teres, teres just means limb, okay, is a tiny ligament from the acetabulum to the fovea of the head of the femur, and has arteries that supply the head with nourishment in the form of blood, right? We can damage the hip. This happens particularly as we get older, okay, and the bones become softer. Fractured hip includes things like enterotrochanteric fractures. There the extracapsular fracture occurs usually in young and middle-aged individuals, usually the result of trauma. Subcapital fractures occur within the hip's articular capsule, primarily in elderly people that have osteoporosis. So this is an example of what we would call a pathologic fracture, something that doesn't become obvious until the break happens, and that reveals underlying disease, in this case, the softening of bone. This can result in tearing of retinacular arteries, and then you get necrosis in the region because you cut off the blood supply to the proximal epiphysis, right? And then that part of the bone can die and shear off. The knee is a complex hinge joint. It's the largest and most complex diarthrosis. It's capable of rotation and lateral gliding when you flex it, and it's made of a tibiofemoral and patellofemoral joint. You can see it here. This is the quadriceps tendon. This is the patellar ligament. This is the medial collateral and lateral collateral ligaments, all right? And there's the patella right inside this dense regular connective tissue. From the back, okay, we can see the popliteal ligament, all right, and the lateral collateral and the medial collateral ligament, sometimes called fibular and tibial collateral, all right, because it contains the names of the bones that are connected to the femur, right? And then if we get inside the knee, you can see the intercapsular ligaments, okay? Looking at the front of the knee here, this is the anterior cruciate ligament. And if you look at the back of the knee here, this is the posterior cruciate ligament. And they keep the knee from sliding back and forth, okay? So with the collateral ligaments and the cruciate ligaments and the popliteal ligament, what you get in the knee joint is something that only moves in one plane under normal circumstances. Note that the goodness of fit between the proximal femur and the distal tibia, the distal femur and the proximal tibia is enhanced by the medial and the lateral meniscus, which are fibrocartilage discs that improve the fit between these condyles and the condyles on the tibia. Okay, sometimes when people damage their knee, they can rip the collateral ligaments, they can tear the cruciate ligaments, and they can also tear the meniscus. Okay, this happens a lot to athletes, as an example. Okay, the structures include an articular capsule that encloses the medial, lateral, and posterior knee, the quadriceps femoris tendon, which we pointed out, the patellar ligament, which runs from the bottom of the patella to the tibial tuberosity, which is a little bump under the kneecap on the front of the tibia, the fibular collateral that runs from the distal femur to the fibula, and the medial collateral, which runs from the distal femur to the tibia. Okay, this prevents hyperadduction in the fibular collateral, and the tibial collateral prevents hyperabduction. Okay, so again, the idea here is you don't want your knee swinging from side to side, right? You only want it bending or extending. You either want to be able to kick or you want to be able to bend your knee. Okay, and the collaterals keep that from happening. The medial and lateral meniscus, again, fibrocartilage discs that improve the fit between the two surfaces and stabilize the joint medially and laterally. And then we talked about the cruciate ligaments, which are inside the capsule and keep the knee from sliding back and forth. Okay, very important as well. When you damage these, you can have what are called episodes of instability, where the knee will bend in a direction that it's not meant to, right? And you'll probably go down in a lump. Okay, this usually happens as a result of a blow to the medial or the lateral side of the knee that you were not expecting. Okay, and then you tear that ligament, and sometimes you don't know about it until you try to move in a lateral direction and the knee goes out from under you. Okay, the tibial collateral ligament can happen when the leg is forcibly abducted. Now, when we talk about the leg here, we mean the lower leg. Okay, so this would be like taking your lower leg and bending it out to the side while we're keeping your thigh straight. Okay, you can imagine how painful that would be. Fibular collateral, when the medial side of the knee is struck. ACL, when the leg is hyperextended. PCL, when it's hyperflexed. Meniscus, due to trauma or overuse. Okay, and also it's sometimes a byproduct of tearing the ACL or the PCL because you can get more play in the joint when that happens. Usually, injury of the tibial and medial meniscus and ACL can be the result of a lateral blow to the knee that abducts and laterally rotates the leg. Okay. All right. So what I want you to do is watch a little bit about the knee. That's coming up next.
The knee is a major weight-bearing joint of the body. Its stability depends on the ligaments in and around the joint and on the muscles which surround it. The joint is susceptible to injury in both the young and the old. If we look at the front of the kneecap or patella is clearly visible. This is a sesamoid bone which forms in the common extensor tendon of the knee. The extensors of the knee are referred to collectively as the quadriceps femoris. They form the bulk of the muscles on the anterior of the thigh. Outlines of the separate muscles can be clearly seen if the muscle is tensed. Behind the knee lies the popliteal fossa. This is a diamond-shaped fossa whose boundaries are marked by the tendons of the muscles which flex the knee. On the lateral side, the most prominent tendon is that of biceps femoris, which inserts onto the head of the fibula. And on the medial side, the tendon of the semitendinosus muscle. The knee joint is formed by articulations between the femur, the tibia, and the patella, or kneecap. The articular surface of the tibia is divided into medial and lateral condyles. These are relatively flat. On the other hand, the condyles on the femur are rounded. Consequently, there is very little congruity between the bones. That is, the femur only makes contact with the tibia over a relatively small area at a time. In life, however, the articular surfaces of the tibia are deepened and the contact area increased by tough avascular menisci made of fibrocartilage. These menisci are sometimes referred to as semilunar cartilages because of their shape. They are attached to the tibia in the midline. The lateral meniscus is the more circular of the two. It is attached to the tibia only at its ends and is relatively mobile. It moves as the knee is flexed and extended. On the other hand, the medial meniscus is more C-shaped and is firmly attached at its margins to the capsule of the joint. Normally, it is fairly firmly attached to the tibia. The menisci increase the overall contact between the femur and the tibia. They change their shape as the knee flexes and extends. Inside the knee joint are two strong ligaments which join the femur and the tibia together. They lie in the midline, between the articular surfaces. When viewed from the side, they can be seen to run diagonally and to cross each other. These ligaments are called the cruciate ligaments. The ligament which arises anteriorly on the tibia and passes upwards and backwards is called the anterior cruciate ligament, while the one which arises posteriorly on the tibia and runs upwards and forwards is referred to as the posterior cruciate ligament. These structures can be clearly seen in this dissection of the knee. The medial and lateral menisci lying on the surface of the tibia, and the anterior and posterior cruciate ligaments joining the tibia to the femur. These ligaments prevent excessive forward or backward sliding of the tibia on the femur. These ligaments are important in very many situations, especially for actions like walking down stairs, where there is a tendency for the femur to override the tibia. The joint is enclosed by a synovial membrane, which secretes synovial fluid to lubricate the joint. This forms a large and complicated shaped sac, which surrounds both the medial and lateral articular areas. However, the cruciate ligaments, which lie in the midline, are outside the sac and are not bathed by synovial fluid. An upward extension of the synovial sac separates the patella and the quadriceps femoris tendon from the femur. This is called the suprapatellar bursa. A pad of fat separates the infrapatellar ligament from the synovial sac. Outside this sac, the joint is enclosed in a fibrous capsule, which is reinforced medially and laterally by collateral ligaments. On the lateral side is a cord-like fibular collateral ligament. This joins the lateral condyle of the femur to the head of the fibula. It is separate from the fibrous capsule of the joint. On the medial side is a flattened ribbon-like ligament, extending from the medial epicondyle of the femur to the side of the tibia. This is virtually inseparable from the fibrous capsule of the joint. The medial meniscus is also bound to the inside of this medial collateral ligament, fixing it firmly to the head of the tibia. Surrounding the joint are the tendons of the muscles responsible for its movement. Notable among these is the tendon of quadriceps femoris, the powerful extensor of the knee joint. This tendon has the patella embedded in it. The inferior part of this tendon, below the patella, is known as the ligamentum patella. Many other tendons cross the knee joint, either on the lateral or medial side. These are from muscles which are primarily involved in the flexion of the knee joint. Many of these tendons have bursae associated with them, which may become enlarged or inflamed. There are also bursae between the deep layers of the skin and the tendons or bones. Inflammation of these gives rise to the common conditions known as housemaid's or clergyman's knee. The main movements of the knee joint are flexion and extension. As the knee approaches full extension with the foot firmly on the ground, there is a small amount of medial rotation of the femur on the tibia. This rotation twists the knee, tightening the collateral ligaments and drawing the tibia and femur into a close-packed configuration. The knee is then described as being locked. Locking makes the knee joint rigid, which is of considerable benefit, especially during long periods of standing. During extension, there is a tendency for the patella to be drawn laterally as a result of the line of pull of the quadriceps muscle. This tendency is resisted by the prominence of the lateral condyle of the femur and by the horizontal fibers of the quadriceps muscle, which draw the patella medially. Before the knee can be flexed, the joint must be unlocked. That is, the twisting which occurs during full extension must be undone. This is achieved to a large extent by the popliteus muscle. This muscle lies deep to the popliteal fossa. It takes its origin from the back of the tibia, and the fibres pass upwards and laterally. Its tendon passes between the capsule of the joint and the lateral collateral ligament, to be inserted into the lateral condyle of the femur and into the lateral meniscus of the knee joint. When this muscle contracts, both the femur and the lateral meniscus are rotated laterally, allowing the knee to be flexed. The 3 C's are the most commonly damaged structures of the knee: the cartilages or menisci, the collateral ligaments, the cruciate ligaments. The medial meniscus is the more vulnerable, as it is attached to the medial collateral ligament and is less mobile. Should there be a sudden thrusting movement at the femoral condyle when the knee is in the semi-flexed position, the cartilages can be torn. The medial collateral ligament is frequently damaged following a blow to the lateral side of the knee. This forces the knee apart on the medial side, tearing the medial collateral ligament. This may also tear the medial meniscus away from its attachments. The cruciate ligaments within the knee are extremely strong. Injuries to these normally require considerable force and often involve damage to other structures in and around the knee at the same time. These ligaments prevent excessive anterior-posterior movement of the joint. They can be avulsed or torn from the bone, for example by a violent blow to the tibia. In summary, the knee joint can be extremely strong, especially when in a stable, extended position. However, when flexed, even relatively small twisting movements can cause serious damage. This damage can be very painful and may cause deleterious effects many years later.
Okay, the talocrural joint, or your ankle joint, is a hinge joint that allows dorsiflexion and plantar flexion, as well as eversion and inversion. Okay, there's an articulation between the distal tibia and talus, and between the distal fibula and the talus. Okay, you can see it here. Note again the ligaments that stabilize the joint. Okay, note the angular movements that are permitted. Okay, but again, we also have the ability to evert and invert the foot as well. Okay, you can see here the ligaments that stabilize on the medial side of the ankle. Okay, the talus is the tarsal bone that projects above the foot and has a smooth surface, C-shaped surface, covered in articular cartilage, and articulates with the lateral and the medial malleolus. The medial malleolus is the bump on the inside of your ankle. It's a feature of the tibia. The lateral malleolus is the bump on the lateral side of the ankle, and that's on your fibula. Okay? So that's the articulation, right? The articular capsule covers the distal tibia, medial and lateral malleolus and talus. The deltoid ligament binds the tibia to the foot on the medial side and prevents over-eversion, right? That would be flipping the sole of the foot outward, right? And the lateral ligament binds to the fibula on the lateral side, preventing over-inversion, but it can be sprained and torn. And anybody who's twisted their ankle has probably torn their lateral ligament, or at the very least strained it, okay? Anterior and posterior tibiofibular ligaments also stabilize the joint. Sprains are defined as stretching or tearing of ligaments with fracture or dislocation, resulting from things like twisting the foot or over-inversion. Fibers of lateral ligaments can be stretched or torn, and you get swelling and tenderness anterior-inferior to the lateral malleolus. A Pott's fracture can occur with over-eversion, where the medial malleolus is torn off the tibia, and that's called an avulsion. It's a very damaging injury. The talus moves laterally and fractures the fibula in addition. Okay? As we age, our joints do not improve, unfortunately. Right? Fibrous joints, mesenchyme differentiates into dense regular connective tissue during development. Cartilaginous joints, mesenchyme becomes fibro or hyaline cartilage. And for synovial joints, mesenchyme forms the articular capsule and supporting ligaments. Then mesenchyme forms synovial membrane, and then may be reabsorbed or form menisci or articular discs. And all during this time, of course, the cartilaginous model of the bone is being replaced by osseous tissue as the bones are developing, okay? With the exception, again, of the bones that undergo membranous ossification, okay? Arthritis is a blanket term referring to inflammation of the joint. There are a lot of different types of arthritis. Rheumatoid arthritis is an autoimmune disease in which your immune system attacks the joint tissue, and you get swelling of both weight-bearing and non-weight-bearing joints. And the fix for this is usually steroidal anti-inflammatory drugs, which have their own side effects, while osteoarthritis is essentially the wear and tear of the joint as a result of a lifetime of use, okay? And so what happens there is that the cartilage wears away, you get bone on bone, and that chips the bone inside the joint capsule, and you get bone spurs, and that irritates and inflames the joint. Exercise is important here. Exercise increases the strength of the muscles that cross the joint and stabilizes the joint so that it's less easy to dislocate, okay? It also increases the movement of synovial fluid into the cartilage and keeps the cartilage healthy. And if this is taken to extremes, right, such as when you play impact sports, all right, like let's say football, okay, it can grind away the cartilage and you can have early onset osteoarthritis. Another way to get early onset osteoarthritis is to become obese, right, to gain a lot of weight. So arthritis is basically a group of inflammatory or degenerative diseases. Gouty arthritis is the result of crystals of uric acid forming inside the joint capsule. It's usually the result of the overuse of diuretics in your diet, such as alcohol and caffeine, okay? And also it's associated with eating organ meats and red meat, okay? So it's a disease of living too well, eating high on the hog. Osteoarthritis we've discussed, degenerative wear and tear on the cartilage that ends up with bone on bone inside the joint and produces the bone spurs that generate the pain. And rheumatoid arthritis is an immune system attack on the joint tissue that causes swelling and pain in both weight-bearing and non-weight-bearing joints. Osteoarthritis primarily on weight-bearing joints, okay? So what follows is a discussion of arthritis, all right, and then a discussion of joints in general, all right? So I will see everybody in the next podcast. Thank you for listening.
More than 40 million Americans have arthritis. The Center for Disease Control in Atlanta, Georgia, predicts that number will increase to 59.4 million by the year 2020. Dr. Arlene Ross, a rheumatoid arthritis specialist, explains what arthritis is and why it is so painful.
The word means inflammation of the joint. And so it's an apt term because everybody understands what inflammation is, and everybody has experienced some inflammation, like an injury, a bee sting. So they know if that happens, it gets red, it gets warm, it gets swollen, and it hurts a lot. And so all of those things happen in the joint which has arthritis.
There are several types of arthritis, but osteoarthritis is the most prevalent. Affecting 15.8 million Americans, it is a degenerative joint disease where the cartilage covering the end of a bone deteriorates. Affecting 2.1 million Americans, rheumatoid arthritis is one of the most serious and disabling forms of this disease. The lining of the joint becomes inflamed in reaction to immune system activity in the body. Treatment varies, but usually consists of exercise, heat, or cold treatments, methods to protect the joints, and possibly surgery. Medications may be used to reduce joint pain and joint swelling may include acetaminophen, aspirin, and anti-inflammatory drugs. The most recent breakthrough in rheumatoid arthritis has been the development of antibiologics that target individual molecules to reduce inflammation.
Articulation is a fancy word for joint. Joints are sites where bones join together to make movement possible.
Joints are divided into 3 different functional classifications based on the degree of movement they allow. These classifications are synarthrosis, amphiarthrosis, and diarthrosis.
Synarthroses refer to joints that are immovable. Synarthrotic joints just won't budge. They just lock bones together. These types of joints are found in places like the cranium.
The classification amphiarthroses refer to joints that are slightly movable. They're not rambunctious or hyper, but they do move a little bit. These joints are found in places like the vertebral column.
And last, but by no means least, the classification diarthroses refers to freely movable joints. These are the types of joints found in upper and lower limbs.
In addition to all this, joints can also be classified by their structure. The 3 structural joint classifications are fibrous joints, cartilaginous joints, and synovial joints.
The first structural joint we'll talk about is the fibrous joint. Some joints have little fluid-filled spaces between bones. These little fluid-filled spaces are called joint cavities. Fibrous joints do not have joint cavities. Fibrous joints are joints where bones are united by fibers of fibrous tissue at their joint sites. Fibers. Fibers. Hey, it's fun to say fibers. One specific type of fibrous joint is called a suture.
Now everyone has sutures in his or her skull. These sutures are made up of interlocking or overlapping bone edges that are connected by short fibrous fibers. The term fibrous fibers may sound redundant, but hopefully it'll make you remember the name of the fibrous joint. 2 other types of fibrous joints are Syndesmoses and Gomphoses.
In Syndesmoses, bones are connected at their joint sites by long fibrous cords or sheaths. Fibrous, get it? You can find an example of this joint in the lower leg between the tibia and the fibula.
Another cool fibrous joint is the Gomphoses. Gomphoses are the joints that connect the teeth to their tiny bony sockets in the jaw. They are attached with fibrous periodontal ligaments.
Are you catching a trend here? Fibrous joints use fibers. Another type of structural joint classification is the cartilaginous joint. Now, can you guess what substance connects bone to bone in a cartilaginous joint?
Cartilaginous joints are joints where bones are connected by plates of cartilage. Like the fibrous joint, the cartilaginous joint has no joint cavity. They are amphiarthrotic or slightly movable and are usually found in the axial skeleton.
You remember the axial skeleton. It's the skull, the vertebral column, the ribs. Yeah, you remember it. Well, a good example of a cartilaginous joint would be symphyses.
Symphyses are flat, frisbee-like discs of cartilage between the vertebrae. The proper name for these frisbees is intervertebral discs. Symphyses are also found between the vertebrae and in the pubic symphysis of the pelvic girdle.
The Synchondroses are another fine example of cartilaginous joints. The Synchondroses are joints made up of super flexible cartilage called hyaline cartilage. These joints can be found in structures called epiphyseal plates. Epiphyseal plates are found in long bones like the humerus and the femur. These plates allow for linear bone growth in places like your arms and legs. That's longitudinal growth.
The final structural classification is the synovial joint. These joints consist of bone ends that are separated by a joint cavity filled with synovial fluid. Synovial fluid is a liquid that reduces friction between bones. Synovial joints come in 6 exciting varieties: gliding, hinge, pivot, ball and socket, saddle, and condyloid.
The gliding or plane joint has a flat surface and allows for sliding movement in between bones. The gliding joints are found between ribs and vertebrae and in the joints of the wrists and ankles. The joints in the wrists and ankles are known as the intercarpals and intertarsals. Makes sense, doesn't it?
The hinge joint, found in the elbow and knee, is made up of the convex end of one bone that fits into a concave groove of another bone. Remember, convex bulges out and concave caves in. The hinge joint kind of works like the mechanical hinge you might find on a door. The pivot joint is another important joint. It has a rounded surface that protrudes into a ring formed by a bone and ligament.
Pivot joints are found between your first and second cervical vertebrae, called the atlas and the axis. Remember, your cervical vertebrae are located in your neck, and the pivot joint is the joint that allows you to shake your head no.
The next major joint is the saddle joint. The saddle joint is found in the thumb and, oddly enough, looks kind of like a saddle. The saddle joint allows for both up and down and side-to-side movement.
You can find the ball and socket joint in both the shoulder and hip. It consists of a large spherical head that fits into a large concave cavity and allows for all types of movement, making it the most mobile joint. In fact, you remember the 3 functional classifications of joints? Synarthroses, amphiarthroses, and diarthroses? Well, the ball and socket joint is a diarthrotic joint because it's super mobile.
Finally, the condyloid joint, located in the knuckles and wrists, consists of a small condyle, or projection, that fits into a small depression and allows for side-to-side and up-and-down movement.
Well, there you have it. You are now a joint scholar. You know about the 3 functional classifications of joints, as well as the 3 structural classifications.
Joint injuries, joint disorders.
When studying joints in the human body, it is very important to take into account common yet very painful injuries. These include sprains and dislocations.
A sprain involves the stretching or tearing of a ligament, which unites bones at a joint. A sprain is extremely painful. Sprains can be partial tears or complete tears.
Partial tears heal very slowly because of lack of blood flow to ligaments. Complete tears must be repaired surgically, and surgery is very frightening. Even if you can bench press